Hello, everyone. My name is Mychelle Dingle, and I'd like to welcome you to the Middle Passage Ceremonies Important Markers Project's 2024 Mother's Day program, The Bridges That Carried Us Over. This will be an incredible conversation with Dr. Mychelle Farmer and Dr. Velvet Miller. Dr. Farmer is the Chief Medical Officer for Advancing Synergy, an organization that seeks to improve access to technology and research for the prevention and control of non-communicable diseases. She serves as a member of the World Health Organization's Civil Society Working Group. She is also a member of the International Association of Adolescent Health, and she participates in the Global Health Council. Dr. Farmer believes firmly in health as a human right. She has a strong commitment to health services that are culturally relevant and technically excellent, and works continuously to ensure that we leave no one behind in the quest for high-quality health care for all women. Welcome, and thank you for joining us, Mychelle.
Thank you so much, Mychelle. It's really a pleasure to be here, especially on this Mother's Day weekend.
All right. Dr. Miller began her career as a professional nurse, practicing in a variety of clinical and academic settings. Dr. Miller is currently the director for the Not One More project, promoting maternal health and preventing maternal mortality. Her focus continues to be ensuring equitable access to healthcare, especially the underserved. In her position in the state of New Jersey, she was responsible for policy, program, and fiscal oversight of the state's Medicaid, welfare, child support, children's health, and disability services. Dr. Miller was awarded a Pew Fellowship for Doctoral Studies in Health Policy. So great to have you here this afternoon, Velvet.
Thank you. It's great to be here. And I have to say, I'm back to the music with the opening of this. That moved me. That got me. Okay, I'm glad I'm here. Hi, everybody.
Great. Well, I can't wait to get into today's discussion. But before we start, I would like to encourage everyone here to ask questions, as we will have about 15 minutes to answer any questions that you may have. Now, if you've joined these webinars before, you probably know what I'm about to say. And that is, if you have questions, feel free to use the Q&A function in Zoom. Try to stay away from the chat feature for your questions. I've already seen the chat feature just filling up with lots of hellos and great comments. But I won't be able to see the questions because they'll get buried in the chat feature. So if you have questions that you would like answered for our distinguished guests, please go to the Q&A function for those questions. All right, with that said, let's get started. I'm going to start off with some questions, and then we will get to the attendees' questions. And Mychelle and Velvet, this is a conversation, right? We are just going to talk for a little bit.
Yes.
All right, briefly, what has been your work and direct experience with Black maternal health? Who would like to start that off?
I'll do it.
Okay.
A few years ago, I was a part of the Indiana University School of Medicine in the OBGYN department, and particularly focused on the family planning aspect of OBGYN services. And my attention clearly was on how come 3 to 4 times Black moms die in this whole pregnancy journey. And I asked several of the faculty, what did they know about what's being done? The research was there, but I was curious to find out who's doing something about this. And the fact is that very few documents showed that much was being done to correct the problem or address it in a way that was meaningful with outcomes that were measurable. So that got me frustrated and sort of led me to start a project that said, we are not going to have one more death in a maternal death, and particularly Black maternal death, if we can help it. And focusing in on Indiana, which along with Mississippi and Louisiana are the worst in our country with maternal mortality, I just started this project and said, what is it we can do And that has prompted me over these years to say, we're doing action. We're going to do something about it, not just research it. So that's my professional experience with it.
Okay. Mychelle,
All right,
what's
great.
yours?
Well, actually, my first exposure to dealing with the issues of pregnancy and pregnancy complications started when I was an undergraduate at Yale University. I had a special grant to do some work in medical anthropology in rural Haiti. I was in a region of Haiti called the Artibonite, and I made the acquaintance of a midwife who was really just locally trained. I think historically in the United States, we often talked about granny midwives. And she would have been the Haitian equivalent of that. I was fascinated. I thought, my goodness, if there's anything I can do to address, pregnancy and its complications, I got very interested. When I went to medical school, though, I must admit I got seduced, if you will, by adolescent medicine and wound up in pediatrics. However, when I began my first career, I spent a lot of time working in reproductive health and pregnancy prevention for adolescents. I was working in a public health clinic that focused on sexually transmitted infections and HIV. And I also helped as the medical director for our school-based health centers here in Baltimore City. And it really brought me back full circle to the importance of pregnancy and prenatal care. That prenatal care doesn't necessarily start when you realized you missed your period and you think you're pregnant. Mm-hmm. It really is should be a part of our routine care for young women. And we might even make a statement about the importance of introducing prenatal issues to young men as well. So that, it's a prenatal process prior to pregnancy, pre-pregnancy care and counseling. And I think that when we're talking about maternal mortality, we have to recognize that this is not just something to be concerned about during the pregnancy itself, but also in that postpartum period. Many studies tend to look at the postpartum risks as something that occurs in a 6 to 8 week period following the delivery. And in many cases in the United States, these state-based systems limit their support of mothers postpartum to 1 to 2 months. And they miss the mark that there's an important period in the entire first year following the birth that really should be protected period for this mother, that pregnancy-related deaths can occur far out past the labor and delivery period. Up to a third of those deaths can occur during that period. And that's one of the unfunded mandates that we need to advocate for our young women, particularly young women of color. We have to recognize also when we're thinking about these young women, is they're not, when they die, they don't just leave children that need to be nurtured. They may have contributed to the economics of the family with jobs. They may be caregivers of elderly people in their family or people with disabilities. All of this really has an economic cost. And a reason why I realized that investing in the lives of young women, even in the adolescent years, would be meaningful to the continuum of care throughout the reproductive years.
Awesome. Now I know, we kind of talked a little bit before we jumped onto this webinar. And if you are comfortable with sharing, do you all have any personal situations that you can share around Black maternal health? Things that you've been through that were struggles for you?
Yes, thank you for that opportunity to share some of it. I personally did not have complications in my pregnancy, but my son and his wife had serious complications and scary complications during the delivery process. And while I X thousand miles away, I get a call that says, "Mom, is this serious? They're putting a tube down her throat. Mom, her blood pressure's gone up and she's in a coma now. Is this, how serious? Are we looking at a death here?" So yes, personally, the pain of not being on site during that time, the pain of hearing my son feel helpless, and the potential of having him raise a child alone was very real and very frightening for me as a grandmother. Yes, I'll leave it there.
Yes.
Thank you.
Yeah. I can certainly relate to what you're talking about, Velvet, because I personally did have an experience with a pregnancy-related emergency. For both of my pregnancies, I had preeclampsia, which was the onset of hypertension in the middle of the pregnancy. It was, managed to the best way possible. But with the second pregnancy, I had what's called a abruptio placenta at home, which was a massive hemorrhage. Right. And I live in an inner city. I had very good prenatal care, but when you're in a home setting with a massive hemorrhage like that, every minute counts.
Yeah.
Thanks to my wonderful husband and my young son, they immediately sprung into action. The only thing I can also add is the good news is that I'm here and alive to tell the story, and my daughter did very well. But I will give one other sort of caveat here, another thing that women of color have to face. And my husband looked at me and he said, "Should we call an ambulance?" And, here I am, my, every breath counting. And I said, "No, don't call an ambulance, because the nearest hospital was not a hospital that knew me and knew my underlying condition. And I was worried that they might think that, is this a woman who's having massive hemorrhage because she's on drugs or any other issue?" And the delay in getting care, because they don't have an understanding of the underlying medical conditions, could have been a fatal error. So I asked him, "Please, you'll have to take me. You'll have to put me in the car." And fortunately, we were able to get to the hospital where I was getting my care, and everything worked out well. But every minute counts. And, we have to recognize that while my condition was, I think a very, unexpected, certainly at the time, many pregnancy-related emergencies are preventable. If you know that there's an underlying illness or condition, and often that's not the case, or if we have people who are attentive to information that, and not dismissive, then we have a better chance of preventing these kinds of emergencies.
Yeah, if I may, two
Sure.
things you've mentioned, Mychelle. One, the importance of bringing our young men, our boys, into the information age about pregnancy and what it means and responsibilities, et cetera. It's never too early to do that. Well, maybe at age 3, that's a little early. But we need to keep in mind that our boys and young men need to be equally informed. The other thing that you mentioned is the impact of post-delivery health complications that are lingering, or a death. The impact that has on not just the family or the woman, but on the community and on the working conditions and the neighbors and the aunts. This has a very big effect and impact that we need to pay attention to and can take advantage of, because it does involve a community, and that we'll talk more about that, I know, but community involvement and acknowledgement of what's going on is really critical. And so I just wanted to come back and respond to those two comments that you made, and I'm glad you're with us. You lived through that.
Yes.
Yeah.
Amazing stories. Thank you for sharing. We're going to go pull up a slide right now. And I think, Mychelle, it is your slide that you'd like to talk to.
Right.
So.
Yes, you know, when I think about maternal mortality, again, it's clear that we need to have a very strong, competent health team. You know, to that second point, the weak primary healthcare systems increase risk for adverse outcomes. But we don't have to be doctor dependent, okay? I think that it's important for us to think about the healthcare system as being multi-sectoral and multidisciplinary, and they must be keenly aware of the social determinants of health. That these social determinants of health are those conditions in which we are born, we work, we live. It's beyond the health system. It's what are the components of the neighborhood, and it's also the living conditions in which someone lives, including looking at environmental factors that can adversely affect a pregnancy. We have to think about the economic factors that, you know, having insurance, and even including private insurance, may not be sufficient to provide that access to comprehensive care that a young woman may need during the pregnancy or the postpartum period. Also, education. We need to make sure, as Velvet brought out, not just educating the mother or the woman, but educating the men in her family, educating the father of this baby. You know, we want to be inclusive so that the men understand and know what they need to do to step up. The former president of FIGO, that's the International Federation of Gynecology and Obstetrics, made a very powerful statement. He said, women aren't dying of diseases we can't treat. They're dying because societies have yet to make the decision that their lives are worth saving. And this is a very important factor that, you know, we have to be committed to providing care, as we talked earlier about that pre-pregnancy care and attention, the prenatal care, early prenatal care, comprehensive prenatal care, and there must be funding available. There must be health systems available that are going to be committed to taking care of the mother and the baby, but especially for this conversation, the mother for that first year postpartum. So I'll stop there.
All right, thank you. That was great. We have one more slide that Velvet is going to talk to as well. So we're going to pull that up right now. All right, Velvet, weathering, you'd like to talk about that?
Yes, and I think there's a slide with the definition of weathering. There it is. Thank you.
Yeah.
Thank you. The information and learning by everybody about what's happening during pregnancy is really important. I recently had a discussion with a mature gentleman who was serious when he couldn't figure out when a woman has going into labor and her water breaks, does that come from where she urinates? Where does that come from? And isn't it just urine? And I thought, this is a man who has children, has been observed his wife deliver, and he still was confused about some of the basic stuff. So getting all of our family members, and particularly men, to understand basic anatomy and the process is really important. Mychelle mentioned those social determinants of health, and they're about where we live, where we play, how educated we are, what we eat, and they're all very important and factors in our health, determining our health, I want to make sure we also consider something that oversees and encompasses all of that. And it's called weathering. It's a relatively new concept that's being articulated as a concept and its impact, but it's been with us for a long time. In fact, probably since we were transported here from outside of America, from other countries, and particularly Africa. Weathering hypothesis is about dealing with the daily insults of racism. It's about dealing and selecting which stressor, which affront, which confrontation you were going to respond to, or say, I'm going to let it slide. And we experience this as African Americans daily. When you go into a store and you're followed, you know that that raises your blood pressure and it offends you. But what's key here, whatever the microaggressions or confrontations you deal with, what's key here is that we live with it daily, it accumulates, and it has been proven to have a strong biological effect on the bodies. Okay, so anybody who deals with stress can have an effect on the body and the physiology and what's happening. What we know now, and thanks to the research by Arlene Geronimus, is that in African American women and men in particular, but African American women have weathering impact, and it affects the pregnancy, the health during the pregnancy, and contributes to mortality in high numbers. We look at weathering in terms of how am I going to deal with this insult today? What have I learned in dealing with this kind of problem? Weathering, and it is an old saying, I just weather the storm, I just get through it and deal with it as it's necessary, can lead to and does lead to chronic diseases like asthma, like hypertension, like higher incidence of infection. So I ask, as we think about the social determinants of health, that we understand we as Black folk are weathering the storm every day, and it has a significant impact on our physical health. So I just want to add that, and thank you for that opportunity, Mychelle. That was a last minute throw in, but it's a real important one.
Absolutely. Before I go to the next question, we're getting a little bit of audio feedback. So if you're not talking, maybe you guys can just mute so that it cuts down on some of the audio feedback. Not too bad, but just make sure you unmute when it's your turn to talk so we can hear you. And I'll make sure, because I'll let you know. But next question. We talked a little bit about some of the things that are impacting Black maternal health and mortality, but are there any patterns that you see that are impacting both the maternal health and mortality nationally, and Mychelle, in your case, internationally? Who'd like to start with that? Just go ahead and unmute.
Well, I think that, just to pick up on the concept of weathering that Velvet brought up, that is a clear pattern that, as she's pointed out, has historically been a big issue. It's interesting that we have set aside or put, to the background some of those support networks that can help mitigate some of that. I mentioned the granny midwives, and that was historically a very important source of support. These were community-based workers who improved access to prenatal care. These are women that had information and experience with pregnancy. And really, I think the outcomes could be better if we resume that. The one component that gives us hope that we might have a return to that kind of support network are the doulas. Doulas provide important information. They provide important emotional support and advocacy for women throughout the pregnancy and the postpartum period. And we need to see more of that because of, the fact that people are very busy these days and their lives are complex, their neighborhoods are complex. And even in the setting of healthcare, digital literacy may be poor. And a doula may also not just help, in terms of informing this woman, but be her digital guide and provide that digital navigation that she may need to get through 21st century prenatal and postpartum care. The sad reality, though, are twofold. One is, again, back to that theme of weathering, mental health is emerging as the number one cause for maternal morbidity. We've just gone through a pandemic with COVID, and mental health took a big hit on all of us, but it's been specifically stressful for women during pregnancy. And we have yet to build or implement within our health systems supports that can reduce weathering. I say that because only 6% of pregnancies, 6% nationally, have addressed or include the support of a doula. And if we look at midwifery, we're still dealing with deficits statewide that way. Internationally, I can certainly say that while communities tend to be generally supportive of women during pregnancy, I think that it's important for us to recognize that cultural norms, particularly for the woman who is pregnant and not married, cultural stigma for an adolescent, even if she's pregnant, she may be presumed to be, less important than an older woman in terms of getting in line and in the queue for prenatal care. So there are many stressors, but there's also, I think, structural limitations in the health system.
And just for educational purposes, define doula for us. Tell us exactly what a doula is.
Well, I don't know. I think I'll just sort of say that this doula is someone who is a very strong advocate and provides a whole range of support services. But I'm going to guess that Velvet probably has a lot more details on that.
And what's the difference between a doula and a midwife?
Oh, okay. Velvet, I'll let you take that one.
Okay. The shorthand that doulas use is that doulas take care of the woman while she's pregnant from the waist up. That deals with what she's eating, that deals with her headspace, that deals with her life activities and questions she may have. A midwife is a professional that deals with everything from the waist down. So she's there to do the delivery, postpartum issues, etc. A doula, though, is fortunately becoming more accepted in the community. She is a non-professional healthcare worker that is an advocate for the woman, or as many are encouraging me to say, the birthing person. But see, the doula is the one you call when you say, I'm itching on my left side very much, and that baby is kicking me a lot. Is that bad? Or is that good? Or what? The doulas are trained to listen to any and all strange, complicated questions and help navigate. That's the word Mychelle used, navigate this person through this process. The key here is that doulas have better outcomes, much like midwives, better outcomes of healthy deliveries, less NICU preterm births, less mortalities in the process. The data is very strong. So having a doula work with you while you're pregnant is a wonderful idea. And having a doula of color is even better, because we know, and it's documented, that people respond and comply far more at far more higher rates if you are of the same color or ethnic background. So doulas are emerging. There's some of us that have sponsored scholarships for doulas, and I'd love to see more. The challenge is also they don't get paid very well. Medicaid programs pay them equivalent to a community health worker, and that's less than minimum wage.
Wow.
Some institutions and some states are trying to improve that. Private insurers are paying more than the state Medicaid programs, and then a private person of wealth, no matter what their color, can afford a doula. But we really need to make this an equitable issue and available to all. So
Yeah, I agree with that. And that is one of the problems, though, with insurance reimbursement, it's incomplete or non-existent.
right.
And when we're thinking about the fact that you brought up, Velvet, that pregnancy complications significantly are reduced with the presence of a doula, these doulas are clearly a cost-saving member of the team. So if we're trying to save money, we should have more doulas.
If we're trying to save lives, we should have more doulas. I'm with you.
Absolutely.
All right, thank you. Thank you for clearing that up, because, in my mind, I was like, doula, midwife, what's the difference? But you make it very clear. Thank you. All right, short-term and long-term, what are some of the ways to address and resolve the inadequacy of healthcare for Black women and mothers?
I know we're rushing running out of time, but I need to add,
I'm sorry.
I know you're going to tell us
about 6 minutes or so before we go to the Q&A. And by the way, before you answer that, I'm just going to let everyone know, if you have questions, go ahead and start putting them in the Q&A, because at around 3:40, we're going to open it up to the folks that are on this webinar to ask you all some questions. But please go ahead and answer that question.
I know you're going to fuss with me, but I do want to say this. Things that impact the outcomes. Let's be real clear. If someone is not heard, and many times our African American women are not heard by their providers.
Yes.
They may have been listened to, but they haven't been heard. That's the key. So the fact that there's an issue about Black women have a high tolerance of pain. No. And the response needs to be rectified. I worked with residents in OBGYN. This is recent now, and they still carry that myth. And it takes a lot to change that, but that's a myth. We need to deal with the things that prompt these outcomes. It's blame. You should have gotten here sooner. You should have had prenatal care sooner. You're the reason you're in trouble, and blaming the person. The other thing is that we don't teach what are the early signs. The pregnant person, the family member, the partner need to know what are the early signs of a problem. And as Mychelle went through, preeclampsia, that's a serious thing.
Yes.
So maybe blood pressure cuffs if somebody has high blood pressure on their third prenatal visit. Maybe just giving them a monitor and have them take it at home. Simple things that can be done. Are there things that prompt these outcomes? Yes. Ignoring people, not answering people, blaming them, not listening to them. There are systematic signs that are promoting and fostering negative outcomes. I just needed to say some of that.
No, I appreciate that. It was actually a question that I was going to ask you, because a lot of these myths and physical racial differences were used to justify slavery, as we were not, quote unquote, human, right? But these myths, they were presented as facts, they were legitimized in medical journals, they confirmed society's view of what enslaved people were, which was not intelligent, that high tolerance of heat, right? So that we can be out in the field, and even higher tolerance of pain, which you mentioned. So I'm glad that you're saying that, because I feel like there's still bias and inequality towards Black health because of those very old fallacies, right? So how do we get that to change? I read that there was a survey that just was recently done where there were white medical students, and it was published in the Proceedings of the National Academy of Sciences, where it showed that half of them endorsed at least one of those myths about just physiological differences between Black people and white people, including Black people's nerve endings are less sensitive than white people. So that's still happening. So how do we get over these tropes that have been lined out there for us since we got over here, right?
I think short
How do we get
term,
past that?
I think short term, we have to be committed to saving the lives of our pregnant women, especially in the Black and Brown community. Just as I said, over 80% of these maternal deaths are preventable.
Yeah.
So I think short term, we have to commit to that. The other issues are long term. I like to talk about the 4Ds, and I think Velvet really hit on a lot of those with hers. Delay in care, that's 1D. Deficiencies in our health systems, we've talked about a little bit about that. And then this issue of disinterested and dismissive healthcare providers. This idea of these myths just allow them to dismiss what a woman is telling them. They seem to be less interested. And then I also think that we have to be committed to providing a more robust system, consistent nationally as well as globally, of data collection, investment in data, so that we have information that is validated, that will allow us to see longitudinally what is happening. And we should expect that with the changes and the strengthening of our health systems, we should see a longitudinal decline in maternal mortality rate. But these are long-term, and our country has to be committed to that. They have to demonstrate that they value the lives of these women, because there are some significant emotional as well as economic costs, to say nothing of the potential death of these young women.
And really quickly, because we're about to go into Q&A, but I do want to ask this really quickly. What is the role of parents or extended family members in the community in advocating for essential health care and support for current and future Black mothers and fathers?
Well, I'm glad you asked that, because it's really important we encourage and foster everyone in that woman's life finding their voice. That means being informed. And I say finding your voice, meaning speak up.
Yeah.
And I believe we need to foster folk to speak up and to be heard. They need to be informed so they can be heard, and they need to speak to the issues that often are glossed over. She didn't say this, she said that, she has a question about this. So speak to that, and then join others with your voice. I say that because it takes a community, and it takes all of us to bring about change in this problematic system that we have. We cannot wait on someone on a horse, I'll say white horse, to come and save us. Parents, families, partners, siblings, aunts, granddads, whomever, need to be, one, informed, supportive, and willing to say, no, 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 this is not normal. We want answers, or we want changes, and we're going to work through getting those changes. This is about life and death. So yes, short-term, long-term, and we can think about, I'm sorry, I know you're going to stop me, but I'm going to say two more things. There are options.
although it's great
There are
conversation.
options that can be taken by so many of the systems. The business community has options in dealing with whom are they going to sign on for an insurance provider for their employees, and does it include maternal or paternal health? Businesses, systems of healthcare, and Mychelle said this, systems of healthcare can make changes, but they have to be willing to make changes. An example is University of Pennsylvania, who said, we're making these changes, and if they aren't evident and we're holding you accountable and they aren't evident by X, Y, Z, your salary's going to be cut.
Yeah.
Systems need to take on this. Health professionals need to recognize their own biases. And I would posit that the older physicians, meaning the attending physicians, we call them, need to understand the impact they have on these residents and medical students, because that's what perpetuates the myths many
You're
times.
listening and learning from them.
Absolutely.
Absolutely.
So we can say to the residents, you've been trained to listen to your patient and check on your biases, but if your mentor doesn't,
Right.
you're gonna copy that mentor.
Right.
Okay, I'm gonna stop.
All
but
right.
I really want to
We've got
say
questions coming in, so I want to go ahead and jump to the Q&A. As a reminder, I see that there's some questions going in the chat as well. Please put them in the Q&A function in Zoom, but I'm going to go ahead and start with the question. The first question comes from Benny Riley. It says, I'm just curious, did we have these problems when Black women were enslaved?
yes.
Yes.
That's a quick answer. Ann Chin, I talked to Ann Chin the other day, and because this has gotten me thinking about a lot of things. On the Middle Passage, what happened to the pregnant women? Did they take pregnant women as slaves? Maybe not, Ann suggests. Well, did they get pregnant on the middle voyage, or didn't they know they were pregnant? And if they did have a baby, what happens? They probably threw them overboard. And while they came to this country as slaves, they brought along traditions of delivery that have been around for millennia. Were they poo-pooed? Yes. Were they responsible for the birth of 90% of the population in the United States early on? Yes. But then they were legislated out and mandated out. Was slavery, did we have the problem of maternal mortality during slavery? Yes, we did. But we have to say those granny midwives really brought through more than not. And their demise is shameful. It's shameful because the laws put them out. The medical profession medicalized pregnancy and delivery and said you have to have a physician to deliver you. You have to be in a hospital to have a baby, and therefore midwives really they're incompetent, unprepared, and they're really witches. Now,
all right, got some more questions. Thank you. Okay. Yes is the answer. They were there. Jamila Chanel or Channel, any suggestions on getting the information to the community about the benefits of having a doula?
Well, I think there's an important need to get the word out. But I also have to say that the services of a doula need to be fully reimbursable through a health system. As Velvet points out, their salaries are not sufficiently high, and but it's still a cost. So those two barriers create two bottlenecks. One is in the access to a workforce, a well-trained doula, and that is not free. And we have to motivate them by letting them realize that there's some economic advantage to a doula personally. Okay, that's number one. But then number two, when this person goes out to do her work, the recipient of that care, or someone who would request that care, the pregnant woman and her family, they need to recognize this as being affordable. So when we talk about access to care, we have to think about affordable care. We have to think about acceptable care. And I do think that the African American community, because of our traditions with granny midwives, would likely be very receptive to a resurgence or an emergence of the doulas. The problem will be, can they afford it?
Yeah. Thank you. All right, I have a question. Can you discuss Black maternal health as it relates to mass incarceration, mothers and fathers in prison?
Wow. Are there babies being born in prisons? Yes, for all kinds of reasons. And the impact is significant in terms of setting, and this is part of your social determinants of health and what happens to a baby and a mother that go through this journey in a prison setting. For a man in a prison setting, there is an equal challenge because they may not have the opportunity to be with their child or with their partner during childbirth and that journey. And the sense of loss or the failed opportunity for early bonding is significant and affects the child in the long term. We have more people imprisoned in the United States than any other country. So we need to think about, what does that do to family? What the lack of partner participation in that process, in the journey, what the lack of it means in the long term. That's a loaded question, and thank you for asking.
All right, another question. Well, actually, a compliment first before the question. They said, thank you for your insight and expertise. How do we convince moms, grandmoms, aunts, etc., that are elder to be open and to be willing to explore some of the challenges that women face without disrespecting their experiences? There are those that view pregnancy or childbirth as, I did it, it was hard, I survived, you can do it too.
Well, again, I think that relates to the need for more community-based education and community-based support. When we think about the issues of weathering, that weathering goes as in a multi-generational perspective. And we have to make sure that all of the generations of women are sensitized and included. As we try to be attentive to these needs. There are increasing numbers of stressors in this 21st century life. And many of us who were born in the 20th century may have a lot of old-fashioned ideas of what these stressors are. And the community-based education model would be very important to have. And I think we really want to think about that as throughout the continuum of the generations, as well as throughout the continuation of the community. That means that information and awareness needs to be integrated into the workplace, into the educational systems, into schools. It needs to be integrated into difficult settings like churches. I'm going to say, why did I say the church is a difficult setting? Well, you know, if you've got an unmarried woman and she's a church goer and she could be 16 or 17, there may be some cultural norms amongst the members of the church that are going to be adverse affecting her. So the church needs to be brought along to be able to uplift and emotionally support. And even in the prison setting, those stressors that you were talking about, Velvet, we need to make sure that they are also given access to that mental health and community support. Incarcerated people live in communities too.
That's right. I'd like to add, when, you know, sure, those of us that were born in that previous century look at the folk now in their maternity outfits and say, oh man, you're showing your belly. You're not supposed to have jersey type things on your belly when you're pregnant. There's a very big difference in generation to generation as to what's acceptable and not. And some of us have to learn to understand where younger folk may be. And some of the younger folk have to learn and hear what we went through and what we learned in our journey. So I share that because all of the generations are pointing the fingers and saying, you did that, or you're doing that. And maybe we need to step back a little bit. I'm still dealing with the real tight jersey pregnancy outfits. I'm still there. I just want you to know I'm working on it, but okay.
I understand. All right, we've got a couple more questions and a few more minutes, so let's see if we can get these last two in. Question is, how are the issues of disinterest, dismissal, and the myth of death within medical schools or professional development how are the issues of disinterest, dismissal, and myths dealt within medical schools or professional development for providers? Is there progress in the training of our medical people?
Yes, I think there is progress. And having been on that line and training medical residents in OBGYN practices, I can say there is a strong trend of trying to make certain that the new generation of physicians are more aware and inclusive and thoughtful and are checking their biases more frequently. The challenge is, can they hold on to that? Because medical education is, and Mychelle, you have to help me with this so I don't sound biased, but medical education is so focused on skill, attention, and less on the quality of the interaction. So yes, I think things are changing. I'm hopeful in many ways, particularly in OBGYN, because there are more women in that practice now than there used to be. And women tend to be more willing to listen and more attentive. I hope that change will be sustained.
Yes, but there's a cautionary tale. I'm sorry, I don't mean to. I'm an optimistic person. I do want everyone to know I'm a glass half full person. But I think we need to recognize where we are, particularly in this point in our history, that we have an opportunity to expand our appreciation and our respect by full implementation of diversity, equity, and inclusion as an integral part of what we do in educating and sensitizing not only the students, but the faculty members across all of the health professions. Right now, there are some of our states who decided that diversity, equity, and inclusion must be eliminated, that their state funding will not allow for that. And what am I talking about? Pregnancy and family and those concepts is diversifying, all right? And what am I saying? I'm speaking about the young same-sex couple, two women, and one of them is pregnant, all right? And we want to lift them up as well. This new emerging family, same-sex family, needs to feel supported by us so that she can have a healthy outcome of a pregnancy and that they can have a healthy family. When we cut out diversity, equity, and inclusion as part of our concept and part of our learning, it's harder for conservative, it's harder for traditional members of the health community to feel comfortable. These are the young people who are more vulnerable to the delay in care, the dismissive care, the deficient care. They're put to the background. So I think we really have to recognize that the concept of parenting may be quite diverse. We also have to recognize that we want to be accepting of multiracial and biracial couples. That also carries, I think, a certain level of stigma in some settings. So there's there's a need to be recognize that education and sensitization is a continuous process, and we need more funding and more rather than less.
Okay. I've got one more question. We are really running out of time. I'm going to try to see if you can answer this in like 30 seconds. Okay. How are we able to get our local medical institutions to see the data and to make a change in the care that is being provided to our community? I know that's a lot, but see if we can do that pretty quickly.
Find one champion.
Awesome.
Find one champion in the system and then grow it, and grow that champion's champion, and grow and just keep growing. That's a short answer.
Awesome. You did it. You actually did it. So thank you so much. Dr. Mychelle Farmer and Dr. Velvet Miller, thank you so much. We do have to end it here. This has been an incredible session. So much good information that came from you all. So many great questions. Great session. And thank you all for joining us today. I truly hope you all were enlightened by this conversation as I was. For those of you who want to view or share this webinar, it will be available on our YouTube channel and Facebook page. I also want to thank Ann Chen, Ann Cobb, Nick Huster, the Middle Passage Ceremonies and Port Markers Project Board, and all who have made this programming happen. And before we end this webinar, there are a few things I'd like to mention. First, if you have questions, please contact the Middle Passage Ceremonies and Port Markers Project. They can be reached at middlepassagemarkers@gmail.com. Secondly, in order for the Middle Passage Ceremonies and Port Markers Project to continue this level of programming, and believe me, this was up there, ladies. We need your support, not only financially, but also with your involvement and appreciation of the significance of this work. So to support the research, promotion, and sharing of the history of our ancestors, there are some ways to donate. You can donate through PayPal or Give Butter. The links to both are on the website, middlepassageproject.org, and it's also here up on the screen. You can mail your donation to Middle Passage Ceremonies and Port Markers Project, P.O. Box 3071. That's in Jacksonville, Florida, 32206. And we also now have Venmo. You can see the information on this screen where you can donate directly to our organization. My name is Mychelle Dingle. Thank you all for joining me. What a wonderful, wonderful session. Have a good day.